Hi, this is Dannette, and this is my observation number 4. And it was an emergency room setting and a patient that came in and needed a blood transfusion. Physical surroundings, there were 3 different areas, and I chose to just discuss the transfusion room because everybody pretty much knows the setting of the waiting room, the triage, a small little ER room. So the transfusion room I thought was more interesting. Glass doors so that nurses can easily view the patients, much like in emergency room settings. They did not, however, have a curtain that could be closed, so that way anybody walking by could kind of check on patients that were in the seats. Seating was very close together, kind of bothersome. There was a restroom in the corner, a couple sinks, 2 TVs, 2 different programs on. Made me, as the observer, crazy. The 2 patients in there, both males, didn't seem to mind it too much. There was a patient, 80-year-old gentleman, presented with lethargy and other things that we'll talk about, but Caucasian, everybody was hearing. The attending ER doctor was about in his 50s, hematologist that came in and worked on the blood issue, several RNs, the primary being African-American female that was the most attentive and took care of the needs of the patient after he got admitted to a room in the ER. Daughter was in attendance, another younger RN, a couple of CNAs, I didn't put them down, and then a tech in the transfusion room. Nice gentleman. List of terminology mostly related to there was a lot going on before this because, of course, they were doing the triage. They were worried about low blood pressure, low oxygen, high pulse rate, but that was not what the result was, and so it ended up being the blood. So I decided just to stick with the terminology that matched red blood cells, hemoglobin level. They had to type match the blood to make sure that the blood type of the patient was compatible with the blood type of the bag that he would be receiving. Creatinine functions, I never say that right, creatine functions, to make sure that the kidneys were functioning well enough to even receive blood. Vitals were taken a lot to once IV fluids started, and the patient was immobilized in a bed and not up and trying to walk around or mess around. The vitals did stabilize to a point where they felt like blood was okay. CBC, they did a complete blood count lab. COPD, a couple of the diagnosis of the patient came up with different nurses as they were passing him off. Iron level, allergic reactions to blood, questions about if he'd ever had it in the past, looking up records. He had been to this hospital previously, so they did have some records they were able to refer to. Anemia, erythrocytes, which are red blood cells, the hematologist, which is the specialist for blood disorders. And again, the creatinine and the renal function all relate to the kidney. Patient was in his early 80s. They discussed cancer, COPD. A couple of times had been in there for transfusions previously, so there's an unknown source of internal bleeding. This time he was brought in from a nursing home facility without a staff by EMS and kind of dropped off and said, "Here," until a family member was able to arrive. Patient was a little bit non-compliant, did not seem to think he needed to be there, did not really identify or admit to the lethargy, and did say he felt weak and a little lethargic, but it was really obvious. Middle of a conversation, boom, out. They would wake up and try to remember the question that had been asked like 4 questions ago, and they let him sleep when he knocked out. So there wasn't an urgency because they had a blood pressure cuff on him and a pulsometer, so they were monitoring that he wasn't crashing when he fell asleep. Of course, it was ER, so it was not the regular patient's doctor. And the dialogue kind of was your typical dialogue, evaluated by 2 triage nurses. Patient kept saying, "I'm okay," as he was nodding off. Triage nurse, easy for me to say, the triage nurses were very efficient, Nice, business-like, but also listened to the patient, took their time, just didn't engage in a whole bunch of his dialogue about not wanting to be there and wanting to get out. Got admitted pretty quickly to a room because he did need to be observed because of the low vitals. Nurse asked questions about what had happened since the patient got up this morning. They were talking amongst themselves about the low blood pressure, how really high pulse, like 101 for an 80-year-old man. He was given the room oxygen IV, and general questions were asked again. The redundancy, the Department of redundancy in the ER, of course, asking the same thing 3 times, the same way. Attending physician did come in and look at the patient records, ordered a hemoglobin test to check for anemia and the possibility of internal bleeding, which by this time, based on the records that I overheard them talking about and knew myself, there has been internal bleeding numerous times that have resulted in a blood transfusion. The patient was still falling asleep, so not a lot of questions were asked by the patient. It was not the first rodeo. He'd been in and out before, so he just kind of slept through a lot of it. Once he got fluids, and he was asking for water, and everybody pretty much ignored him. Once he was able to get water, he kind of perked back up, that along with some IV fluids, some saline, or not saline, I'm sorry, potassium and magnesium was in the IV fluid, so that kind of brought him around a little bit. Hemoglobin results were 6.2 and a transfusion was ordered. My understanding that those of us walking around with normal levels, it's, 13 and above. When you get below that, you're getting a little low. When you're getting in the 6, you've got a lot of blood loss. Ooh, I see a typo there. Sorry about that. Or I hit the key. If. General questions were asked and answered about if he'd ever had problems receiving blood before. You can be allergic to the blood, or you can actually reject the blood if it's not compatible. So asking general questions, looking in the chart to verify the things that he said. Hematologist walked in, walked out, power in the room. Everybody stood up a little straighter, walked back out. Controls that the nurses used or demands, I guess, that they faced were trying to make the patient comfortable, trying to make sure that the vitals stayed up, made sure that he did not get agitated, which would could further lower the blood pressure. So just really trying to make their motions not in a hurry, not in a rush. When they talked to him, they weren't in a hurry. They didn't chit-chat. It wasn't personable, but, they were doing their job and keeping a really tight eye on him. Got to the transfusion room a while later. Blood type, everything came back a go. Got him bagged up, sitting 2 chairs down from the other patient that was in the room, so they didn't have to sit, eye to eye together. A technician came in once the other patient had already started a transfusion. Once the gentleman that I was observing started, the tech would come in and just check on both of them, ask them basic questions that I have written down here. The demands there were to make sure for the tech that nobody was so flushed that they were getting overheated, which blood can do, making sure vitals were not dropping, that they were staying hydrated at the same time they were getting the transfusion, and check on their needs. If they needed to get up at some point, then he needed to go with them to the restroom to help maneuver all the equipment and to make sure that they were stable and didn't fall. The end result, much to the patient's chagrin, was a 24-hour admittance to the hospital for observation, typical after blood. Sometimes you can do it outpatient, but I think that would be a younger patient that also didn't have a diagnosis of cancer and COPD. So they really wanted to keep an eye on him. Chief complaint was the lethargy and the tired, which was a result of the anemia and the blood loss. Doctor ordered the unit of blood, monitored the vitals, did the IV fluids in the admission. Patient didn't really ask a lot of content questions. Just talked a lot about why was he there, did he have to stay, when am I leaving, did you give me the right blood? I found myself almost laughing a couple times, but I did not. some interpersonal demands when he arrived and during triage. He alternated between being slightly agitated and falling asleep. I think that presents demands when they're trying to document information. They were efficient, like I said, didn't respond to that. I was watching them as he closed his eyes, and their looks were like pointing to the blood pressure and then to the high pulse and kind of and trying to look up information as they were proceeding to do small tests on him. They made sure that he could feel his feet, that the typical questions that you ask that he was able to answer. Once a patient was in a room, the staff, even though it's ER, were not one-on-one with them. They were two-on-one, so they were in and out of the room pretty frequently, like I said, and attentive, but the demands were there for the patient. I want to see my doctor, I want to go home, I want some water, I'm cold, I'm hot now, just the variation. Just really, some of it, in my opinion, was probably attention seeking, and some of it was not being all cognitively there with the low blood. Not a lot of conflict or miscommunication necessarily. He didn't realize what condition he was in. So that in itself was a conflict between what he believed and what medically was being seen. Top 5 demands. I believe the patient's vitals were consistent with a potential emergency. Very typical of losing blood is when the face is white as a wall, white as a sheet, and that's the way he appeared upon admittance. The lethargy and falling asleep during treatments could have been potentially hazard if he'd fallen out of a potential demand hazard if he had fallen out of a chair, hurt himself. It just didn't look safe. There's an unknown cause of internal bleeding. That's a huge demand for an ER room admitting somebody for acute care to deal with. Patient was also elderly and brought in by EMS without an ID or any assistance until family arrived. My thought world, I was like, wow, how can he walk and talk and be here? How would I feel if this was me and I was elderly and I felt, I don't know, I kept thinking of the word abandoned. EMS brought him in and the family member was called later. Pretty easily got there, but still, that's stressful. You're 80 years old and sick. I wondered about a lack of coordination, if that could lead in some misdiagnosis. ER doctors are snapshot. They see you. You're right there. Their demand is go, do it, diagnose, treat, discharge. It would suck to be old and have health problems. It really would. It would be tough to depend on ER for care, which a lot of people, we understand, especially in vulnerable populations, that's their control. Physical distractions were minimal. It was really cold in both the places, which, if I was interpreting, would have caused some difficulties with, just warming up, making sure my hands were flexible. And I've been in really cold situations before in a chicken plant where it was very difficult. The demands there to interpret were physically hard because it was so cold. This reminded me a little bit of being in the chicken place. Placement of the chairs and IV poles, they were just close together. It's too close for comfort. And then the TV's on. Same time, different programming. Wouldn't have been a demand potentially for a deaf person except the visual aspect of it, or if they had some hearing or a cochlear. But in general, a deaf person could have chosen to watch one screen or the other and read the captioning. Probably more of a demand for hearing people. I like medical work. I don't get easily flustered by patients that are deaf that get agitated. Usually the agitation is not geared towards me. I'm talking for a long time. I like this kind of assignment. I expect it to take a long time. I didn't prep for this because I didn't know it was going to happen, but I am familiar with hemoglobin levels, the kind of scope procedures that they can do to check and see why internal bleedings happen in endoscopy, a colonoscopy. And that's it. Thanks, Stephen.